This is the most subdued and ready to rock Meds Ed audience we've ever had. We're actually also starting relatively on time here today, which we are a big fan of. So let's go ahead and, enough of me talking, let's move forward. This is our agenda for the day. Times are a little approximate on here, but this will give you some idea of the content we're gonna cover. You're gonna hear an opportunity, I think you all probably saw that in our email yesterday, where everyone can share successes or things that you've all implemented in your different environments that you feel are working. Let's have a chance for those folks to share that information here today. And if we're firing on all cylinders, we'll have some extra time for a panel question session at the very end. So that's kind of where we're going. A refresher from the invite that you all probably used to sign up for today. We do have these 3 learning objectives: key reasons for hospital admissions, leveraging pharmacy as a resource in new and impactful ways, and systems to provide a little bit better insight into appointments and discharge coordination. So I think you're gonna get a lot of good practical advice here today and a lot of really cool perspectives. So let's not waste any more time and let's dive right in. We have 2 of our best here to take you through this today. I will pay you later, don't worry. But to take us through our presentation this morning and sort of act as your ringmasters, we have both Jane Duck and Mariah Alford. Jane Duck, RN, has an extensive background working with diverse, complex populations across the continuum of healthcare. She's been with us here at CareOregon for the past 3 years as High-Risk Populations Program Manager, where she helped develop and implement a model for transitional care and outreach. From our very own pharmacy departments, Mariah Alford, PharmD, BCPS, is a pharmacy clinical supervisor here at CareOregon. Mariah received her PharmD at Oregon State University and completed a general practice residency at the Portland VA Medical Center. So it's really hard to shock her. Her clinical practice experience includes hospital medicine, transitions of care, and managed care pharmacy. Are you ready to go? Let's get started. Please give a warm welcome to Jane and Mariah.
Thank you. You're up first.
Oh, I think I am.
We thought before we get started, and I know we'll probably still have people trickling in because I know some people that were coming that I don't see their faces yet, but we have, I think, a really diverse audience, and so for some of you, this information, you've heard it hashed and rehashed many ways. For others, it may be new. We've done presentations in the past couple of years around transitional care and kind of best practices and protocols and those kinds of things. We thought what we'd do today is kind of take you through some sort of high level, just little bits to get you thinking and get you talking and be able to take something hopefully back to where you practice and where you live to start using it as a think tank. What can we do with this information? How can we think about this more? How can we use this? So you're just going to get little pops of stuff. Okay.
Okay, so I am here to not talk about causes of readmission for 15 minutes, but to kind of set the stage for the problems that we're trying to solve and some of the data that we've got over the last years, especially since implementation of the ACA and some of the Medicare penalties for 30-day readmission rates, and sort of looking at setting the stage for what we know and where we might be able to improve a little bit. So I just wanted to separate these out by lines of business. So all of the populations, as you probably all are aware, are very different in the types of patients they tend to center around. So for Medicare, the most common causes of 30-day readmission rates, heart failure, sepsis, pneumonia, and COPD. That probably doesn't surprise anyone when we're talking about a population that's generally over the age of 65. For CareOregon, most of our Medicare members are also duals, so they also have Medicaid. And so you can see here, by diagnosis for 30-day readmissions for Medicaid, it really switches to mood disorders, schizophrenia, so a lot of mental health. And then we drop down into diabetes, complications of pregnancy, and then alcohol-related disorders. So substance use disorder is a huge one for CareOregon. And it presents a really different problem, right, than heart failure, sepsis, pneumonia, and COPD in terms of how we keep these people out of the hospital. For our members that are duals that have Medicare and Medicaid, we're probably looking at some heart failure with some mood disorder happening in the same time in the same person. So how are we going to work with those people to hit both their physical health and then their mental health disorder? And just as a comparison, these are the common readmission rates for commercial insured patients. So patients that are generally employed or have a spouse that's employed and are getting insurance through a commercial plan. So chemotherapy, radiotherapy, so cancer, mood disorders, and then complications of surgical procedures, complications from grafts or device implants. And then sepsis comes in at number 5. So way down at the bottom of this list is diabetes, heart failure, and COPD. So the lists really flip depending on the type of patient that you're talking about. So when you're out in clinics, I know that we have a lot of our clinic partners here that work specifically with underinsured Medicaid members. So this list doesn't really apply to many of your patients, but just in general, kind of what we're seeing in our hospital system, since you're taking all payers, it can be really different. And the interventions that are necessary to keep these people out of the hospital change dramatically. So this is some Kaiser Family Foundation data from a few years ago. They got really excited in about 2015, 2014 to present to us the falls in hospital readmission rates for the first 3 disease states that Medicare was looking at in terms of penalties for 30-day readmission and looking at the dramatic decrease. So this article that this is taken from talks all about how we've all implemented programs to communicate and help coordinate transition for all these members, and we can see that coming through in the numbers with dramatic reduction in 30-day readmission. Well, unfortunately, this is the latest data, came out about a week ago in the New England Journal of Medicine. So on your left is 30-day readmissions for inpatient discharges, and you can see since 2007 that those numbers have come down nicely, about 12, 13% down. Inpatient down almost 19%. So hooray for us. But you see this little one at the bottom here where observation stay 30-day readmission rates have actually gone up by almost 80%. So, and then on the right is the 30-day readmissions after observation stay. So they came in the first time for an OBS, and then they're coming back within 30 days. All readmission events are up almost 36%. Inpatient are up 9 or almost 10%. So they went to OBS first, they come back, they're admitted. And then you can see OBS, and then OBS again is up 92%. So overall, probably it's about even. Sorry, it's also evil. Slip. But observation stays, so we generally know. So when I was at the VA, observation patients are treated exactly the same as inpatients. I know that's not the same at most hospitals. So these patients generally are getting a less coordination of care coming out of observation stays. And I know from the health plan side, because the inpatient or observation status can switch several times during a hospitalization, that we have a really hard time figuring out who's who and what sort of hospitalization they've had. So overall, when you look at per 1,000 discharges, the numbers are exactly the same as they were in 2007. So we really haven't actually moved the dial on readmissions. We've moved the dial on inpatient readmissions and moved them into an OBS status. So we have work to do, I think is the main point from that slide.
Can I just interject
Yeah.
here too? Because we're going to be talking about some root cause analysis, but Mariah's first slide's talking about the types of disorders that cause the most readmissions in each of these population groups is really good information, for instance, to take back to your clinics and your hospitals, because that you can use that to figure out how you're going to problem solve and intervene and create your interventions around those disease states based upon your population.
Do you have any data about length of stays in relationship to the admissions and admissions? I have a hunch that with that some people get readmitted because they were discharged too late?
We don't have that here today, but there is some research, and in fact, just recently there was research, a piece done around premature discharges and short length of stay based upon financial needs. So the hospitals are running out of beds, and so we open beds and we discharge, and that has been a cause, an increase of readmissions. Yeah, and we'll talk a little bit more about a couple of studies in a bit. Yeah.
Okay, and this just came out the beginning of May, and I was so excited to show you all since I'm a pharmacist. And this is my background. This is the work that I did at the VA. The hospital directive is that every patient that discharges from any service speaks to a pharmacist, and they review their med list before they leave. So they leave with a paper copy, and they are fully counseled, and the medications are provided at bedside. Every patient, every time. So OB stays, surgical stays, inpatient stays, all of that. And so this is some research out of Einstein Medical Center, which is in Philadelphia, showing that pharmacist involvement in discharge for Medicare members reduced all-cause readmission rates by 50%. So from 20.4 to 9.8%. Yeah, so a really big deal. The VA has a lot of other issues around discharges, mostly related to members. Heart failure, there were some people that knew me by name. They'd be in so frequently. I'm sure you all have some of those as well. So there's a lot of non-modifiable factors in terms of the healthcare system, but pharmacist involvement in discharge makes a huge difference. Medication errors and medication confusion are one of the largest pieces, one of the largest problems we see for readmission rates.
Okay.